Welcome everyone to this webinar. I think we've got a fantastic session today. Two fantastic speakers as well. Co-hosted by the Community of Practice of Long-acting Therapeutics for Maternal Health and Paediatric Health here in the University of Liverpool. And from the Psychiatry and Trust Group of the Pharmacogenomics Global Research Network. I think we have a couple of chairs joined also. Professor Daniel Mueller and Professor Chad Busman should have joined. Hopefully, I'm not sure how well the connection is from Canada. I think they're based in, but fingers crossed they'll be able to connect okay. This is very much going to be an interesting session focused around long-acting injectable antipsychotics, which are being increasingly used to enhance treatment adherence, and yet their use during pregnancy raises important clinical and pharmacogenomic considerations. And this session is really going to explore current evidence, guidance, LAIA use in pregnancy, maternal and fetal safety considerations, risk-benefit assessment and decision-making in perinatal mental health, and a range of pharmacogenomic insights related to these. So before I introduce our first speaker, I did just want to cover some housekeeping. So just to note that this session is being recorded. Q&A should be enabled. If anyone has any issues trying to raise a question, just to let me know or raise a hand, but you should hopefully see a Q&A at the top of your screen or somewhere, or maybe at the bottom. But just look for that if you want to raise a question while the speakers are speaking or at the end. But also, of course, if people would rather speak than raise a question with typing, do feel free to raise your hand and I can go around and unmute anyone who would like to raise a question. That's perfectly acceptable as well, and we can just work through whoever's raised the most recent questions as we go. So hopefully that's fairly clear. We've got a fair number of attendees coming in, and so we'll try to keep a lid on too many people speaking at once. So, as I mentioned already, this is very much this is focused on clinical and pharmacogenomic considerations for the use of long-acting antipsychotics in pregnancy. And for our first speaker, we have James Lee, who is the lead perinatal mental health pharmacist at Devon Partnership NHS Trust and a credentialed member of the College of Mental Health Pharmacy. He's worked in mental health in the NHS since 2012, spanning a wide range of inpatient and community services, and was part of the team that established the mother and baby unit in Exeter. So, James, I don't know if you'd like to be able to see if your screen sharing is hopefully working.
Yeah, lovely. Thanks, Andy. Right, let me have a go at sharing the screen. Good afternoon, everyone. It's nice to see everyone virtually. Like I say, my name's James. I'm the lead perinatal mental health pharmacist at Devon Partnership Trust in the southwest of England. That's really just a fancy way of saying I'm the only pharmacist who covers perinatal services in Devon. And I guess my aim for this afternoon is to give you a bit of an introduction to long-acting antipsychotic injections, and I guess thinking about their place in pregnancy and that sort of perinatal period. Please feel free to jump in with any questions as you go through if you want to, but we have got plenty of time for sort of questions and answers at the end, so that may well be the easiest place to talk about it. I guess just want to acknowledge from the start that there's probably likely to be quite a bit of overlap between mine and Jeff's talks. I don't want to steal all of Jeff's thunder, but it's probably a good thing to have some overlap because it will hopefully reinforce the message of how important these medicines are, and I guess hopefully just reinforce the whole message. But my aim from my part of the talk is to really have a little bit of think about introducing you guys to long-acting antipsychotic injectables. I don't know if you all come from sort of mental health backgrounds, but I'll do from the ground up so we're all on the same page. A little bit of chance to think about their safety and evidence in the pregnancy context, whilst also building on where they fit in terms of a treatment pathway for patients with serious mental illness, thinking about some of the changes that might happen during pregnancy and what that might mean for how we use some of these medicines. And I guess just thinking about sort of the practicalities of what that might look like for a patient in the clinic room in front of you. So I guess a good place to start then, isn't it, is to give a bit of an introduction as to what these medicines are and where we use them. If you're not aware, long-acting antipsychotic injections are what they say on the tin. They are long-acting formulations of antipsychotics, and we'll talk about the general categories that we split these medicines into. But we generally formulate these medicines into either an oily base. So a lot of the older versions of antipsychotics are formulated into an oil base where the drug itself leaks out into your system over a period of weeks. Or some of the newer formulations are formulated into an aqueous base, which is generally sort of microspheres or nanoparticles, which break down over, again, a period of weeks to months and release the drug into the human body. They're all given by deep intramuscular injections, and where we use them. So most of the antipsychotics now, long-acting injectables, are licensed for schizophrenia, psychotic-based disorders. But what we would say is that these group of medicines are really just an alternate formulation for any place where antipsychotics might come into play. So we are increasingly seeing off-label use of some of these injections for things like bipolar affective disorder, where antipsychotics are essentially sort of first-line treatments. So an alternative route to deliver a very important group of medicines. So what antipsychotics do we have available? We actually don't have as many as we'd like, but we do have a few different versions of long-acting injectables available to us, and there's sort of different reasons why we may pick some over another. We generally break antipsychotics into two categories. First group are the first generation antipsychotics, and these are the antipsychotics which were discovered before about the 1990s. Some of the common names that you might have heard of are things like haloperidol, zuclopenthixol, flupentixol, Clopixol, and Dapixol are the brand names that people commonly recognize. These older group of medicines tend to be very strong D2 dopamine blockers in the brain. That's how they exert their antipsychotic effect. Because they are fairly non-specific, we have a lot of potential side effects that come alongside these group of medicines. The most common ones that we tend to see are those that are movement disorder based. So we class these as sort of these extrapyramidal side effects. So by blocking dopamine in the brain non-specifically, we end up having a load of extrapyramidal side effects, which is an all-encompassing term which describes a load of things like akathisia, so that feeling of restlessness, internal restlessness, muscle dystonia, so involuntary muscle movements, and Parkinson-like side effects. The sort of movement disorders are sort of characteristic of these first generation antipsychotics. They're generally given in the gluteal muscle, so the buttock, and alongside that, I guess, carries a load of potential stigma and concerns about patient vulnerability. Some of them are licensed for thigh muscle injection as well, but most of them are sort of gluteal muscle injectables, and can be given in a range of different ways. So we tend to see them given in somewhere between weekly injections to up to every 4 weeks. That tends to be the maximum license interval that you can get from first generation antipsychotics, and a real wide range of dosing. That sometimes has its advantages. It allows you to really fine tune what dose you're giving to a patient. It also has a potential load of disadvantages where people can overshoot or be imprecise in terms of what dosing we're giving to patients. I guess a major advantage of some of these first generation antipsychotics, because they've been around for so long, is that most of them are they're all off patent now and are therefore very cheap, which makes them very accessible for a range of people. The other category of antipsychotics, which we would break them down to, would be the second generation antipsychotics, and this tends to be the group of antipsychotics discovered from about the 1990s onwards. And I guess the common examples that we see would be things like risperidone, paliperidone, its active metabolite, and things like aripiprazole and olanzapine. These tend to be less strong dopamine blockers, although that is how we think they exert the majority of their effects. But because they have a less strong binding affinity to dopamine receptors, we see less of those those movement disorder side effects, and tend to be more along the metabolic side effects that we associate with these group of medicines. So patients commonly complain of putting on weight, finding that they have raised cholesterol from being on these medicines for long periods of time. The advantage with a lot of the newer second generation injectables is that they can be given as a deltoid injection, so in the shoulder, which tends to be a much more palatable for patients, although a lot of the very long-acting antipsychotic injections tend to be given still in the gluteal. And the intervals are changing quite a lot now. We're seeing new products coming out with much greater intervals between the dosing, but it tends to be injections at least once a month. Some of them, the sort of longer acting paliperidone injections, are now can be given every 6 months, so 2 injections a year, which is really quite interesting in terms of how often we need to have patient contact. And what we tend to see with these second generation antipsychotics is that they have a much narrower dose range. So things like aripiprazole, there is just a single injectable dose that we tend to recommend for most patients, with very small changes that might happen if they're on enzyme inhibitors. And that allows, I guess, less precision for individual patient characteristics, but it also allows less chances for things to go wrong in terms of picking the wrong dose. The problem tends to come with these drugs is that they're still on patent or have ongoing patents for them, which means they tend to be fairly expensive. And I guess if we make that sort of comparison between the first generation and second generation, we can see that those cost considerations can play quite a significant part if we're switching everyone across. I guess it's important, whilst the individual papers may show some advantages between the two, there is very little reason clinically to pick one drug over another. They do tend to work about as well as each other, and really the differences between them come down to things like cost, side effect profile, and maybe the site of administration. Now, why are antipsychotics important, and why are antipsychotics particularly important to be formulated in these sort of longer acting injectables? Well, I think the main reason is because getting antipsychotics into people and keeping antipsychotics in people is really important, particularly when we're thinking about serious mental illness, such as conditions like schizophrenia and bipolar. We know that adherence in general terms, humans are just generally pretty bad at remembering to take medicines every day, all the time. Antipsychotics, when we're thinking about treatment of schizophrenia, tend to be a lifelong treatment course where we would be expecting people to be taking them every day, and that has a significant burden on people. And we know that adherence rates to medicines, particularly in conditions such as schizophrenia, are particularly low. So again, this is a slightly older study from 2011 in Finland, but looking at adherence rates just a month after discharge from inpatient wards. And we're already seeing that in that first month after discharge, over half the patients have already discontinued taking their oral treatment. So we are concerned that that's not going to get better as time goes by. And these tend to be replicated no matter which country we look at and the length of time that we follow up patients for. Patients just don't want to carry on taking these medicines for long periods of time. And the reason that's important is because if patients with serious mental illness miss doses of their medicines, they are at a much higher risk of relapse. And over the course of a year, that can be quite significant depending on how many doses they miss. So we would say that even missing some up to 10 days worth of medicines over the course of a year doubles your risk of requiring a hospital admission. And that isn't a lot of tablets that you need to be missing. So getting medicines into people is really important for keeping them well and keeping them out of hospital. I'm going to show you a load of graphs which just reiterate that fact now, but this is data from back in the day, 1979, looking at fluphenazine, and the description of proportion of patients surviving is sort of slightly misleading. It's proportion of patients surviving in the community, but we can see that over the period of time that we follow up patients for, patients who are stabilized on longer acting injectable versions of the medicines do better than patients on the oral equivalent. So for fluphenazine, as the months go by, we start to see a separation out between the patients who stay well on the depot version and patients who relapse on the oral version. And that sort of graph, I'm going to show you lots of very similar looking graphs. That sort of graph is the same no matter which drug we look at. So if we're looking at patients on risperidone, slightly different. They flipped it around a bit, but here we see that about 50% of patients on oral risperidone have relapsed and had a further psychotic episode within a year. If we're taking the proportion of patients on a longer-acting injectable version of risperidone, then it's less than 10%. That looks the same if we're thinking about drugs like aripiprazole in a longer-acting version. The patients on a depot version relapse a lot quicker than the patients who are on a longer-acting injectable version. And again, same graph, isn't it? Same sort of data that we're seeing every time. Patients on paliperidone 3 monthly and 6 monthly, the vast majority of patients who are on them stay well, and that's really important. I guess hopefully that just highlights why we would be really keen for people to be on longer acting injectable versions of antipsychotics, because they are a really important treatment option in a very serious medical condition. I guess, where do antipsychotics fit in terms of treatment guidelines, sort of nationally? Most treatment guidelines tend to recommend long-acting antipsychotic injections in a place where patients have either struggled to adhere to their medicines or express a preference for them. I have to say, we tend to undersell. I think that we undersell the advantages of patients being on long-acting antipsychotic injections. There, I guess, is concerns about it being a sense of coercion or people feeling dunned to. But actually, if we're having proper informed discussions with patients, we should be able to tell them about the advantages of these medicines over oral treatment equivalents, and the outcomes are better. Our Maudsley guidelines in the UK have now sort of shifted a little bit more to be much more proactively pushing the advantages of longer acting injectable versions of antipsychotics, and they go as far as to say that all patients who are admitted to an inpatient ward for their first episodes of psychosis should be given a long acting injectable before their discharge, because we know the amount that lasts in their system then is really significant, and that has an advantage in preventing them from getting unwell again in the future. I guess what that place looks like in terms of pregnancy, I'll come on to talk about some of the pregnancy specific risks in a bit. But NICE, that's the National Institute of Health and Care Excellence in the UK, they set our sort of national clinical guidance. It's a slightly older guidance, it hasn't been updated for a while now, but tend to say that we shouldn't be starting women on depot injections during the pregnancy. And they make this sort of slightly weird statement that unless a woman's doing well on a depot or previously not taken her medicines, we shouldn't be carrying on the depot. I tend to think that you're probably not taking a depot injection unless you're responding well to it or haven't taken oral treatments in the past. So it's a slightly strange statement. I guess it's also really important to recognise that by the point someone finds out they're pregnant, these drugs will hang around in your system for weeks to months after you make that decision to stop it. So even at the point when you find out you're pregnant, stopping that drug is likely to mean that the medicine hangs around in your system for the whole of the pregnancy anyway. Probably all you're doing by stopping it is just increasing the risks of relapse. And the Canadian guidance, which actually came out sort of relatively recently in the last year or so, recognises that despite these drugs being really important treatment options, we have very, very limited data about using them in pregnancy, and that tends to fall out as really just a few case reports, a few small case series, and most of the data that we're getting around antipsychotic injectables is extrapolated from their oral equivalents, which we maybe have a little bit more data about. So I guess that probably leads us nicely now to think about those specific drugs and what safety data we have about using them in pregnancy. As with all medicines, or almost all medicines that we might use in a pregnancy, it's never clear, it's never black or white, it's usually some form of grey, isn't it? And it's about weighing up the risks and benefits of continuing that medicine, and also weighing that up against the risks and benefits of stopping that medicine. We've talked about the fact that these drugs are used for serious mental illness. And we know that stopping medication during the perinatal period, and particularly during a pregnancy, massively increases a woman's risks of relapse during this time. For conditions like bipolar affective disorder, that can be really significant. We The data sort of varies depending on the study, but we'd say about 20 to 30% of women might relapse who continue on their effective medication during pregnancy. For women who stop effective medication during pregnancy, that can increase to about 70 or 80% of women relapsing. We know that the outcomes for baby can be poorer for mums who have poorer mental health during the perinatal period. That can look like things like increased use of alcohol use, increased smoking rates, reduced input from midwifery services. But also we know that if women have psychotic episodes during the pregnancy, that roughly doubles your risks, the outcomes that we'd be most scared about. So things like miscarriages, stillbirths. So it's often about weighing up the risks of stopping those medicines, which tend to be pretty severe, against the benefits of continuing on any sort of medicine during this time. Like I've mentioned just a second ago, we have very, very limited data about using antipsychotic depots during pregnancy. Most of the data that I'm going to talk about on the next slide or two is based on the oral equivalent. So for the paliperidone, based on the paliperidone oral treatments, we think, I say in sort of vague terms, we think that the vehicle that delivers the antipsychotic doesn't have any concerns during pregnancy, but there's a lot we don't know, and this is why I guess we'd be keen to see more studies investigating particularly the use of long-acting antipsychotic injections during the pregnancy. There are some potential advantages, though, of using injectable versions of antipsychotics during a pregnancy. And the big one is that because the drugs don't undergo first pass metabolism, is that we potentially would see more stable levels of patients' drugs throughout the course of their pregnancy, rather than seeing bigger peaks and troughs. And I'm sure Jeff's going to talk about the changes that happen a little bit during the pregnancy and how that might impact on different drug levels happening during the course of a pregnancy. And I mentioned it already, haven't I? But if a woman discovers they're pregnant and they're already taking an antipsychotic injection, then stopping it is likely to just increase the risk to the mum and to the baby, therefore, rather than making any material difference, because that drug will hang around. The long half-lives of these medicines mean that they'll hang around for weeks and months, even after we make the decision to stop it. I guess just reflecting then on what the data tells us for using medicines like antipsychotics, and again, just recognizing that most of this data is based on those oral equivalents. The evidence that we have so far suggests that as a group of medicines, they tend to be fairly reassuring in the outcomes that we see. So taken as a whole, the evidence doesn't suggest that antipsychotics as a group are major teratogens. They don't seem to be linked to major increases risks of miscarriages, stillbirths. I'll talk about neurodevelopmental concerns on the next slide, but spoiler alert is that they're not particularly linked to those either. We would so the UK Teratology Information Service, who are our sort of national experts on drug use in pregnancy, would recommend drugs like olanzapine and quetiapine as first line when we're going to be using antipsychotics. There is theoretical increased risks of things like gestational diabetes, because they both potentially causes metabolic side effects and increase the risks of weight. So there's something we need to be monitoring for quite acutely during a pregnancy. But actually the data for most of the antipsychotics, again, newer drugs tend to have less data, but it tends to still be very reassuring. Even drugs like risperidone, which has potentially a very small increase, absolute small increased risks of potentially cardiac malformations, we need to be weighing up what that risk looks like against the risk of not being on that medicine. Often if a mum's doing well on something, the best thing you can do is probably to leave her on the thing that's working well for her, particularly when we're using it for serious mental illness. I guess it's also important to acknowledge that taking any medicine during a pregnancy carries some risks, doesn't it? And I guess the big one which we would want to make mums aware of is the potential risks of things like poor neonatal adaptation syndrome, which is basically a potential risk with any drug that crosses the blood-brain barrier and presents a bit like a sort of a withdrawal symptom, a discontinuation symptom in baby. Tends to be fairly mild and fairly short-lasting. Babies tend to be a bit more irritable, a bit more restless, and there's no specific treatment that we need to give for babies, but other than just making sure that we're monitoring them and keeping them comfortable. But it is often a reason why mums on antipsychotics would be advised to give birth in hospital, so that they got the extra support there to keep an eye on baby. a big concern for any mum taking a medicine that affects their brain is the potential impact on baby and on babies' brains, and understandably so. We live now in the world of big data, and the advantage for some of the oral treatments, which are used much more commonly, is that we can collect much more population-based data and follow up babies and compare them over periods of time to other babies who haven't been exposed to these medicines during pregnancy. And most of the data, pretty much all the data that comes out, is pretty reassuring. And if you look at the number of women who are included in some of these studies and the length of times that they're following up babies for, it provides lots of reassuring advice that we can give to women about continuing their medicines during pregnancy. So they often tend to come from America or a mix of Scandinavian countries, but most of the studies are showing reassuring information about the longer term impacts of these drugs, suggesting basically very little impact on them in terms of their neurodevelopment over long periods of time, which is reassuring. I guess Jeff will talk about this a little bit more when he comes onto his side of it as well, but just recognizing that during the pregnancy, lots of physiological changes obviously happen to the woman's body, and that has a potential impact on all parts of drug metabolism, drug elimination, drug absorption, drug distribution. And so we just need to be cautious of how we use some of these medicines, whilst also recognizing we have very limited information in this. This is a great place to see growing over the last few years, and hopefully as time goes by, we'll get more information about what this looks like. But we know that there are changes to how a woman's kidneys functions, how certain liver enzymes are up and down regulated, circulating blood volume changes, particularly changes in muscle mass and fat distribution, which is going to be important when we're thinking about some of these injectable versions of medicines. What that means for longer acting injectable antipsychotics, we almost have no information to guide us on that. And actually, the data we have from oral equivalents is very limited. So if you look, I'll just put some of the various antipsychotics which we might see on the page, but you know, some of that information on haloperidol is based on 2 patients. Now, is that really applicable to the general population? I think it's quite unlikely to, but at the moment we have very limited information to guide us. What we would say at the moment is we're still at the point where we're probably treating the person in front of us rather than being able to be smart enough to make specific advice changes around people's doses during the course of a pregnancy. But I think it'd be naive to expect there to be no changes to how drugs are metabolized during the course of someone's pregnancy. Like I say, it's hard to know what that means for a longer acting injectable, but it's likely that their metabolism is changed. We just don't have the data to really talk about that in much detail. And I guess just sort of to finish off my part, it's really just to say that we need to be thinking about future pregnancies whenever we're prescribing any medicine to a woman of childbearing potential, and making sure that we've considered what those drugs might look like from a future pregnancy, making sure that we've had those discussions with the women so that they're aware, if and when they decide to get pregnant, of what the implications might be. Again, the most important thing is that risk-benefit discussion. It's important that we try and do that as in advance as possible, because like I said, the point a woman finds out she's pregnant, it's unlikely we're going to be able to make much changes to a drug treatment at that point. And I guess consideration to what it means to a drug use during the pregnancy, whilst acknowledging that we have very limited information in that field to guide us at this stage. And that is it for me. Does anyone have any questions on my bit? Or if you're happy, we can jump straight on to Jeff, I'm presuming.
James, I can see one question in the chat there on pregnancy safety and PK data for LAI antipsychotics. So and the fact that they remain sparse. How are policy frameworks incentivizing the generation of evidence from prospective pregnancy registries, real world data, modeling, or hybrid approaches? Or are they not yet compared with areas, say, like HIV?
Yeah, I mean, I think it's tricky because I think obviously we all know, don't we, like, drug research into pregnant women has always been an area of fear when it comes to any investigators. I mean, Adoni might want to come in, but the plan is that we try to look a bit more into some of these things. So I think at the moment, University of Liverpool are running studies looking at the use of some of the mostly first generation antipsychotic use and what that looks like. The plan is that we're exploring the idea that we might try and expand that to try and get more data around second generation antipsychotic use and what that might look like going forwards. I would say that we're still in a bit of a catch-up phase. I'd say drug research in pregnancy itself is very much, we're behind everywhere else. Drug research in mental health itself is sort of a double compounder. It would generally the poor man's relation when it comes to physical health research as well. So a long way to go. There isn't particularly much incentive around researching these things as well, particularly for these older drugs which have been around for very long periods of time. But yeah, I think there's hope. I think we're at the place now where we're starting to see more.
That is reassuring, and yeah, hopefully we do see more, because I haven't worked in clinical trials myself for so many years, and you do see this as sometimes it's such an issue in protocol development and design when trying to get to that consideration for pregnant or lactating females. I do see another question. Do we know what percentage of pregnant women are prescribed long-acting antipsychotics? It'll be a wide-ranging question, but
Yeah, no, that's a good question. I mean, the numbers are small. I think the numbers are small, and I think there's potentially lots of different reasons for that. So I guess, I cover in my team, we cover the whole of Devon. I think at the moment we've got 2 or 3 women on antipsychotic injectables across the whole county. County's about 1 million patients. Small numbers. There are a few different reasons as well. So we would probably say that with first generation antipsychotics, which potentially raise prolactin levels, that may have an impact on fertility, can cause sexual dysfunction and amenorrhea, which might impact on women's abilities to get pregnant in the first place. We tend to see that those serious mental illness conditions, particularly conditions like schizophrenia, that the fertility rates are lower than what we might expect in the general population, although the number of unplanned pregnancies are higher than what we might expect in the general population. So I think, realistically, the numbers are low. That probably reflects maybe the underuse of longer-acting injectables themselves, and particularly the underuse of longer-acting injectables in a pregnancy. I don't have the specific numbers, though.
Well, thanks very much for that, James. If anyone else does have any other questions they would like to raise, do feel free to continue to add into the Q&A, or particularly in the Q&A section, which you'll see in the top left of your screen. And we can come back to them at the very end when we come to a bit of a open discussion and forum. But now, after thanking James for a very fantastic, really intriguing presentation, I'd like to pass over to Professor Busman, who is part of our co-hosts. If you'd like to go ahead and it'll be introducing our next speaker.
Yeah, thanks, Andy, and thanks, James. That was a great presentation. And it's my pleasure to introduce Dr. Jeff Bishop. So Dr. Bishop is a professor in the Department of Experimental and Clinical Pharmacology at the University of Minnesota, and a board-certified psychiatrist. Board-certified psychiatric pharmacist. I'm making you a psychiatrist today, Jeff. He is also leading expert in psychiatric pharmacogenetics, and he's leading the co-development of the Clinical Pharmacogenetics Implementation Consortium's antipsychotic prescribing guidelines, which I think you'll get a sneak peek at in this presentation today. So really looking forward to your talk, Jeff, and take it away.
All right. Well, thanks so much, Chad. And thanks, Andrew and Chad and the other members of the organizing committee for inviting me to be a part of this. It's very exciting. And James, I just want to reiterate what Chad said. That was an awesome presentation, and I think what I have will build on some of the things that you've presented, and then delve into some of the pharmacogenomic aspects of LAIs that can be layered onto the additional complexities that come along during the pregnancy timeframe. So let me just get my slides queued up here and see if we can do this. All right, is this coming through in presentation mode?
Yeah, I can see that fine.
Okay. All right. So what I'll do during my time here is, I'll talk a little bit about the available long-acting injectable formulations, but what I'm going to do is maybe layer on some additional nuances related to drug metabolism pathways and how that's, sort of sets a foundation for how we might consider pharmacogenetic variation. I'll talk a little bit about pharmacogenomic influences on antipsychotic medications in general, and then get into what data we have on hand for quantifying those in the context of LAIs. And then lastly, consider the real and theoretical intersections of pregnancy and the pharmacogenomic influences and how we can consider these things together and their implications for clinical care of our patients. So just as another way to set a foundation for discussion here. So I'll talk a little bit about antipsychotics in general, maybe in a slightly different way. As James mentioned, they were originally indicated for treatment of schizophrenia. We have a growing list of other indications or uses. I'll say that at least as we quantify it here in the United States, there's growing utilization, especially in mood disorders. So as augmentation strategies for depression, treatments for bipolar disorder. I don't have international prescribing data, but we do capture prescribing in the United States through a standardized process. And usually there's about a 1.5 year lag in the release of these things. So the most recent data that became available at the end of 2025 quantify utilization from 2023. In the context of antipsychotics, quetiapine, aripiprazole, risperidone, and olanzapine are all in the top 300 prescribed drug list. And as you just heard, 3 of these, aripiprazole, risperidone, and olanzapine, all have long-acting injectable formulations available for them. In the United States, just these 4 drugs represent just shy of 24 million prescriptions and almost 5 million patients. Again, just for these 4 drugs, and that encompasses both oral and long-acting utilization. When we look at challenges in continuation of therapy, you saw a little bit of this from what James mentioned, but there are really high discontinuation rates, particularly within the first year of starting new antipsychotic medication. And this is, again, not necessarily specific to LAIs, but a challenge with antipsychotics in general. And the reasons for the discontinuation can vary across patients, but I think largely they fall into 2 buckets, and there are 2 categories, and that being tolerability or side effect, adverse event types of scenarios that are disincentives for individuals to continue therapy, and then lack of efficacy or effectiveness that unfortunately occurs as well. So for both of those categories, I think we're having a growing understanding of how background genetic variability can help us increase the precision with which we consider the selection or dosing of a number of different antipsychotic medications. So you heard a little bit about the advantages and disadvantages of LAI, so I won't go into this in great detail because we've already covered it. I think maybe just a couple of things that I'll highlight from the positive side. We get a bit more clarity in adherence and when the last dose was because of the sort of structured scenario in which individuals have to receive their injections. And so in the context of adherence challenges or other things that patients have going on that are barriers to taking their medication, this is a way that we can more accurately track that than relying on self-report. And then I think the other thing from the LAI standpoint is just because of the longer duration of action, if we have to make dose adjustments, we have just the extremely longer lag time or period that occurs between our timing of a dose adjustment and observing the reality of those effects, just because of how long it takes the body to achieve a steady state at a different higher, lower dosing strategy. So I'll talk a little bit about the available formulations, but just maybe highlighting in the context of what the metabolism pathways are. So you heard about some of the first generation agents here, which I have a similar list, but I just wanted to highlight as a backdrop for some of the pharmacogenetic considerations that for first generation, or sometimes they've historically been called atypical antipsychotics, fluphenazine, haloperidol, and zeucobenzithixol all have metabolism pathways that go through CYP2D6. Let's say for fluphenazine and zeucobenzithixol, those are fairly well categorized as major pathways. Haloperidol, in those studies, gets categorized as minor, but as a maybe a hint of what you'll see on subsequent slides, there does seem to be some 2D6 impact, at least on oral formulations of that medication, that can lead to meaningful dose adjustments. Now, this is maybe a bit more of a scary, busier slide, but I think I can distill this down into some take-home points. The first of which is that for second generation, or previously known as atypical antipsychotics, we have 4 different drugs with long-acting formulations: aripiprazole, olanzapine, paliperidone, and risperidone, and a whole wealth of growing formulations that give us some flexibility for dosing in the arm or in the gluteal muscle, a range of frequencies. And as James mentioned, we even have some formulations of paliperidone that go out to every 6 months. So when we look at the metabolism pathways for these medications, CYP2D6 is relevant for primary metabolism of aripiprazole and risperidone. Paliperidone is predominantly eliminated unchanged and has limited hepatic metabolism. Olanzapine has a number of metabolizing enzyme pathways that are involved. I'd say 2D6 is generally regarded as more minor and doesn't really result in any pharmacogenomic influences, as we'll talk a little bit about more later. So before we get into some of the LAI specific considerations, I just wanted to highlight a little bit about what types of pharmacogenetic guidance is available for some of these medications at the current point in time. And generally, the recommendations for pharmacogenetic considerations come, at least I have them categorized from 3 different places. So the product labeling, as we categorize it from the United States Food and Drug Administration, or FDA, the Dutch Pharmacogenetic Working Group, and the Clinical Pharmacogenetics Implementation Consortium. So these 2 entities have consensus guideline groups that get formed to then evaluate existing data in the published domain, and then how to consider those in the context of known pharmacogenetic information for individuals. And so I think what I wanted to highlight here is that for haloperidol, perfenazine, thioridazine, and zeucobenzithixol, they all have some recommendations across these entities for pharmacogenetic guidance related to CYP2D6. There's some differences in how, say, for example, CPIC and Dutch Pharmacogenetic Working Group, we both consider, maybe more detailed information across drug metabolizer phenotype. So for 2D6, those are generally considered as poor metabolism, which is an absence of or non-functional form of the gene, or a complete deletion of the gene. Intermediate metabolizer, normal metabolizer, and an ultra-rapid metabolizer. And ultra-rapid is generally a phenotype that's derived from gene duplication or multiplication in some way. So I think the highlight here is that we have some detailed dose adjustments, particularly as we think of them from DPWG and CPIC for these first generation agents. And again, these are in general, not specific to long-acting injectables just yet. And then for second generation agents across these three entities, aripiprazole, brexpiprazole, iloperidone, risperidone, and quetiapine all have some pharmacogenetic guidance. You may see X's in some categories, for example, the FDA or Dutch group and the CPIC. And some of that variation comes from how the available data that, for example, maybe comes to the FDA, but then doesn't get published into, translated into publications in the private domain, or differential selection of medications that are picked up for a formal evaluation across the guideline groups. But I think, again, the theme here is that for all but one of these drugs, the gene that's of relevance here is cytochrome P450-2D6. The most profound dose adjustments are generally in the poor metabolizer category. You can sort of see some themes of 50% or essentially halving of the usual starting and maintenance doses for poor metabolizers is a trend that you'll see across medications. Quetiapine is one medication that has a Dutch pharmacogenetic working group guideline for CYP3A4, which is a different metabolic pathway. So their evaluation of those data were to make some evaluation and dose adjustments based off of that, but that's not in the CPIC or FDA guidance. So I think it's sort of all source information and highlighting how we have a good wealth of information to inform some of these adjustments if you have genetic profiles for these genes. Now, as James was mentioning, you have some impacts of drug distribution and disposition over the course of pregnancy, and some of that is related to physiology changes. And so I want to reinforce that and also highlight that we do have some molecular impacts of pregnancy on antipsychotic relevant drug metabolizing enzymes. So I picked out three here just to highlight: CYP1A2, 2D6, and 3A4, because those are relevant for probably the majority of currently available antipsychotic medications. And what's really scientifically interesting but also clinically challenging is we have different directional effects on the activity or expression of some of these enzymes over the course of pregnancy. So, for example, CYP1A2, which is a primary metabolic pathway for olanzapine, it's involved with haloperidol biotransformation, clozapine, as well as others. This activity actually decreases over time during pregnancy, and on the other end of the spectrum, CYP2D6 and 3A4 actually have increased activity. So these mechanisms can be linked back to either some inhibitory functions of hormones that increase over the course of pregnancy, that then decrease activity of 1A2, but conversely increase the activity of CYP2D6 and 3A4. So a lot of these medications, which I'll highlight in a bit more detail on subsequent slides, go through maybe two, if not all, of these pathways. So you have some opposing effects that occur just at the molecular level for these enzymes, and then layering that on top of genotype is what we're hoping to just sort of inform the group and listeners on as part of this session. So some of the other considerations have already been touched on. I'll just highlight that some of this is directly in line with what James had mentioned. I'll just comment that and reinforce that, unlike oral medications, if we're during a course of therapy of a long-acting injectable and something is not going well, our ability to stop and immediately have a washout of the medication, so to speak, is a lot harder for long-acting injectables because of how long they stay in the body. And also some of the metabolic impacts for some of the second-generation drugs, risperidone and olanzapine, They might increase the risk of maternal weight gain and gestational diabetes. We don't have, I think the data that quantify that in the context of pregnancy is a lot less than what we have in the general population, but they are potential considerations that must be weighed into the pros and cons of selecting therapies. From drug-specific safety profiles, you heard a little bit about the prolactin elevation from paliperidone, risperidone, and the first-generation agents, as well as the neonatal adaptation syndrome that can occur with some of those drugs, particularly that are tight D2 binders. I'll just add aripiprazole has a lower risk of elevating prolactin because it's a D2 partial agonist, which could preserve maybe some of those effects on normal lactation. On the other hand, aripiprazole is a medication that tends to have a bit more akathisia or restlessness that results from therapy. So depending on the presentation of the individual, if they have maybe some anxiety, anxiousness types of symptoms, which are perfectly normal to occur during the context of pregnancy in general, but could also be a part of the phenotypic expression of somebody's diagnosis, then that might be a consideration for aripiprazole as opposed to some of the other medications. The other one, olanzapine, has a unique risk of this post-injection delirium sedation syndrome, or PDSS, which essentially comes from an unintended bulk release of some medication that's rare, but has resulted in a special monitoring program, at least in the United States, that comes along with that. So I haven't had experience with an individual taking that olanzapine long-acting injectable, but there are some unique risks associated with it that could indirectly be considerations for a neonate. So I'll jump now into some aspects of specific medications and how they may be influenced by pharmacogenetic variation. Aripiprazole is metabolized by CYP2D6 and 3A4 and perhaps 3A5. And so remember, those were enzymes that were maybe have increased activity just over the course of pregnancy. It has the active metabolite, dehydroaripiprazole. Sort of the combined sum total of those two is generally thought to be the main active component. But with increased activity, you may have a shift in the ratio of the parent to metabolite. So as it relates to more specifically to long-acting injectable formulations, if we look at the product labeling, there is some specific dose adjustment that's recommended, at least by the FDA, highlighting that in known CYP2D6 poor metabolizers, the adjusted dose would be down to 300 milligrams. And so the usual dose, just for those who aren't working in this area, is generally recommended to be 400 milligrams. So based off of the data that were submitted to the FDA for product new drug applications, they quantified that dose adjustment. But there have subsequently been a few published studies quantifying genotype impacts of CYP2D6 on aripiprazole long-acting injectables across genotype or metabolizer groups. And I'll highlight two of these examples and how they are translating to proposed dosing recommendations. So this is a study of over 600 individuals who have been stabilized on either oral or long-acting aripiprazole. And I think for the aripiprazole formulation, it was the Maintena formulation that's administered every 4 weeks. Essentially, these are individuals who are at steady state. These figures here quantify the ratio of combined active metabolites, dose-adjusted concentrations for aripiprazole LAI, the oral formulation, and their overlay. And so what I'll highlight here is the combined combination of the active and parent and metabolite across ultra-rapid, normal, intermediate metabolizer, and poor metabolizer groups here on the x-axis. Really shows sort of a nice stair-step genotype-related impact on on those concentrations, with poor metabolizers slightly higher than intermediate, and ultra rapid metabolizers being a little bit lower. Albeit, we do have smaller numbers for some of these extreme ends, but you do see similar patterns for the oral formulation. Maybe in that context, IMs look a little bit more similar to PMs in oral as opposed to long-acting. But when you plot their overlay, they're behaving reasonably similar, at least enough to maybe consider adjustments in a similar fashion. So a second example, a slightly smaller study sample. This is about 74 patients receiving aripiprazole once monthly for at least 4 months at 400 milligrams per month. Again, what you have here is on the left side, we have just sort of the active component, and on the left side, the dose-adjusted active component in across CYP2D6 phenotype in panel A. And then panel B is the parent drug, and then panel C is the ratio. And so what you can see here is, if you're focusing just on kind of the active moiety, you see some you again see some of the stair-step impact across poor, intermediate, normal metabolizers, which then gets captured in some of the parent to metabolite ratios, highlighting that there really is a differential conversion of active drug to the metabolite, but the total active component also seems to be impacted as well. And so these are just the LAI data. There are a number of other publications that have highlighted some other additional clinical outcomes related to switching and discontinuation in oral formulations. But at least as these translate to LAI dose adjustments for aripiprazole based on 2D6, what I have here are proposed adjustments, at least as they're coming out of our CPIC guideline group. So we're sort of just admittedly in the tail end of this, but these are where we're standing so far, and we'll hopefully get this into the published domain in the not too distant future. So for ultra rapid metabolizers, we have because of some of the smaller numbers of ultra rapid metabolizers published, we have implications that you might have subtherapeutic levels, could be a risk of non-response or relapse. How to make a formal dose adjustment in an individual who has maybe 2 or maybe more copies of CYP2D6 is unclear. So our guidance is to use therapeutic drug monitoring to guide dosing. For intermediate and poor metabolizers, we have recommendations to reduce the dose by 25 to 50% for both of those categories. We have we categorize CPIC recommendations with a strength of recommendation. So optional really highlights how either the direction or magnitude of the effect might be unclear, or there's some differences in opinion on the guideline group of how to consider that. Moderate and strong essentially means that we have a bit more data to stand on, and the 25 to 50% dose adjustment range highlights some of the variability that might occur across data as well, data sources, as well as the available formulations that we have to achieve that in a clinical scenario. Risperidone is the next medication that I'll talk about with respect to pharmacogenomic influences. As we highlighted before, there's a number of different formulations that can be administered from every 2 weeks out to 2 to 4 weeks. It has similar features to aripiprazole in the sense that both the parent and the metabolite are active. The metabolite, as was mentioned before, is 9-hydroxyrisperidone, which is actually marketed as its own entity, paliperidone. It goes through both CYP2D6 and 3A4 pathways. Again, both of those are altered in the context of pregnancy, aside from pharmacogenetics. And just to reinforce, paliperidone has limited hepatic metabolism and doesn't really have pharmacogenetic genetic relevance, and does have some of those formulations that can be administered for longer periods of time for individuals who have achieved good stability. If we look at the product labeling for risperidone, there's some acknowledgement of 2D6 in there. No specific dose recommendations are made, although they do offer recommendations for individuals taking a strong 2D6 or 3A4 inhibitor or an inducer. But we look at published data. This is just one example that highlights some of these impacts across genotype group. And so what we have here on the left-hand side is risperidone parent drug from long-acting injectable across CYP2D6 metabolizer groups. And then here on the right, we have the total active component, which is parent plus the 9-hydroxy risperidone across 2D6. And so for both of these, what you can see is especially for poor metabolizers, profound effect on increased dose-adjusted concentrations, and then you see lower exposures or lower concentrations in ultra-rapid metabolizers, and at least here we see a bit more similarity for intermediate and normal metabolizers, and that was a bit variable across studies. And then a second example in a little bit of a smaller study sample sort of reinforces the some of those stair-step types of influences. Here we have parent drug, metabolite, total active component, and the ratio all plotted across CYP2D6 metabolizer groups. And we need to take a little bit of caution with some of the interpretation, because in this context we only have one poor metabolizer, but we're able to really maybe parse out some of the differences across intermediate and extensive or normal metabolizers and ultra-rapid metabolizers. So these are a couple of examples of how this looks in risperidone long-acting injection. And again, this is a two-week formulation. So the way this is proposed to translate to dose adjustments of LAIs based on 2D6 genotype, some similarities, but also some nuanced differences as compared to aripiprazole. Again, for ultra-rapid metabolizers, we do have a therapeutic drug monitoring recommendation, but we also have a primary recommendation of selecting an alternative. And I think, at least for some other data that maybe weren't necessarily specific to the long-acting injectable, there was greater some more connections to clinically significant drug discontinuation or switching over time. And then we have an optional recommendation for a 25% dose reduction in intermediate metabolizers, and that's because some of those studies showed some differences, but some more similarities with normal metabolizers. And then for poor metabolizers, reducing the dose by 25 to 50% or choosing an alternative. Again, there's some other data that connect these outlier metabolizer phenotype groups with treatment discontinuation and responsiveness over time. Zuclopenthixol is the first generation medication that I'll highlight with long-acting recommendations that are resulting from it. As mentioned before, it's a first generation drug, primarily metabolized through CYP2D6. This is one that's not used in the United States, but does have notable international use. In an international label, it doesn't have pharmacogenetics mentioned in there, but there are accumulating data for both the oral and long-acting formulations that highlight differences across 2D6 genotype groups. This was one relatively recent 4 or 5 years ago study that quantified clopixol dose-adjusted clopixol levels across over 1,100 patients using this LAI formulation gathered from a therapeutic drug monitoring service. And again, what you see here is profound increases in poor metabolizers. Intermediate metabolizers are in between. And for this context, we had some more similarities between the normal and ultra-rapid metabolizers. I think there's, when you consider the oral data for the oral administration. There's a bit of variability in the ultra-rapid metabolizers, as well as just a lower frequency of data points to assess that. But some subsignals that you have variability in those exposures for ultra-rapid metabolizers. So the recommendations coming out that are being proposed for Zuclopenthixol, LAI, use therapeutic drug monitoring to guide dose adjustments in ultra-rapid metabolizers, reducing the dose by 25 and 50% in intermediate and poor metabolizers. And these are both, when I have these summarized in these slides, it's the starting dose as well as the maintenance dose. So generally, if we were considering LAIs, ideally people would already be on a maintenance dose, but that transition sometimes has some different journeys depending on the patient and how they're getting to be taking a long-acting injectable. So other long-acting injectables and pharmacogenetic implications, haloperidol. Haloperidol is one that I showed you in one of the earlier slides that has some general recommendations for dose adjustments in poor metabolizers. All those data were based off of oral administration data, and there weren't any published data to quantify the long-acting injectable pharmacogenetic effects. So I think we need to use some caution in extrapolating, what we're seeing from the LAIs to the oral to the LAIs. I think clinically, and based off of what we're seeing for some of these other drugs, it makes some sense that there might be an effect, but we don't have any specific long-acting recommendations that would get formalized in a publication just because of those lack of data. Fluphenazine is another one that I mentioned that had a primary CYP2D6 metabolism pathway. There really weren't much, if any, pharmacogenetic data for fluphenazine at all. So it's another one that falls in that category where it seems like there could be an impact, but we just don't have any objective data to base some of those adjustments on. Olanzapine and paliperidone, there aren't any LAI PGX studies that have been published to my knowledge. Those studies that have been examined with oral formulations really don't find any pharmacogenetic influences for either of these medications that would result in any clinical adjustment. So in the last couple of slides here, what I'll do is kind of translate from thinking about the pharmacogenetics, maybe in isolation, to how this intersects with the during the period of pregnancy. And just as there's a general lack of data examining LAIs in pregnancy, was highlighted earlier, there's pretty much little to no data examining the pharmacogenetic components of this. So it's really a wide open area in need of further data. So where that leaves us is sort of a situation where we need to think about what we know about what happens during pregnancy, and we need to think about what happens as a function of genotype, and then we can overlay those to perhaps improve our clinical judgment and precision given what we know and what we don't know. So a couple of things that I wanted to highlight as considerations. First of all, the actionable pharmacogenetics that we have is currently restricted to CYP2D6. Now, at least two of the medications that I highlighted that are very commonly used, risperidone and aripiprazole, are both metabolized by 2D6 and 3A pathways, which genotype aside have their own upregulation, and some other medications may, like haloperidol, have influences across all three enzymes, So, but when we think about overlaying some of those transcriptional or molecular changes, one thing to keep in mind is that molecular induction can't turn a poor metabolizer into another CYP2D6 phenotype, because even if you have more of a non-functional structural variation floating around, you can't make it active if it's not active in the first place. The other way that someone can have a poor metabolizing phenotype is if they have a complete deletion of the CYP2D6 gene. And so in that context, you really can't induce anything. How that relates to intermediate metabolizers or some types of intermediate metabolizers, that's another area in need of further clarification. So what I'm trying to highlight here is that we have some knowns and we have some unknowns, and the intersection of these gets a little bit complicated and it's hard to predict. So as we think about synthesizing this is a bit of a conceptual model that I put together with some help from Gemini AI assistants to maybe start to think about a model of how you conceptualize the intersection of pregnancy and pharmacogenomics. And I think as from what we heard from James earlier and what I have is kind of a synthesis of where we're kind of landing right now. And on the left-hand side over here, we have considerations related to maternal physiology and changes across pregnancy. So changes in organ function, total body blood volume and water, filtration rates, liver function, all those types of things. Pharmacogenomics here on the right, so genetic variations. Primarily related to CYP2D6 are where they're most actionable and how we can translate those to phenotypes. And then in the middle, having the intersection of these things that then filters down into how we can consider these intersections for maybe improving the precision with which we select and dose medications during pregnancy or even over the course of pregnancy and then beyond. So it's really complicated in an area that's definitely needs more data to quantify how these things all work together. So the last thing that I'll do before I'll just wrap up is a little bit of a promotion of something that we've started here at the University of Minnesota. It's called the Pharmacogenetics ECHO, which is extension for community health outcomes. And essentially, ECHO is a way to have case-based presentations. This model was developed in the state of New Mexico for providing some opportunities for individuals in rural healthcare settings to present cases in the context of expert groups for feedback. We've developed one focused on pharmacogenomics. It's free to attend. We haven't had a case related to antipsychotic LAIs at all, or pregnancy at all. But we do have a number of individuals who join, and if you want to sign up, it's free, and you can go through the QR code here to sign up. So appreciate the entertaining my self promotion a little bit here, but we do feel like there could be opportunities, and it could be relevant for all that we're talking about today. So with that, I'll end my time, and I haven't been able to see the comments show up. So happy to entertain any questions that have come up in the chat or what people are thinking about right now. So thank you so much.
Yeah, I can go through a few questions here, Jeff, and I think a couple of people have their hands raised. But since I'm just going to go through these kind of in order in relation to Jeff's talk first, and then I think there's a couple left over from James's as well. So
Okay.
First towards yourself, Professor Bishop. One was in relation to when accounting for the overall antipsychotic activity, should we attribute that to risperidone, paliperidone, or the active moiety?
That's a great question. So and I think the answer is yes. So I think there's value in the sum total, but also parsing out the maybe the individual components. I think generally it's thought that the active moiety is the sum total of the parent and the metabolite. So that's where I generally go to first. I think there may be some appreciation. Maybe it may be more sensitivity in younger patients for maybe paliperidone having a little bit more prolactin elevation, but so that relative distribution, I think, That ratio isn't as quite as linked to clinical outcomes as much as it is just sort of quantifying the sort of metabolism capacity of an individual. So I'd probably lean towards the sum total first, and then the paliperidone component second. And if you don't have genotype, you can always look at that ratio and anchor it back to some therapeutic drug monitoring guidelines that are out there to sort of see how much that's deviation from what is normal. And you can have either genotype or other reasons why somebody might be have faster altered metabolism in some way.
Oh, thank you. Sorry, I was on mute. I do see another question for yourself as well, Jeff. Thank you from Sandeep Pushpakkam. Do you foresee a difference in the level of CPIC evidence and therefore a difference in recommendations between LAIs and oral formulations in this context?
That's another great question. I know we've got at least one other person from our group, Chad, on board here. We had extensive conversations of whether to separate those out or to group them together. And where we've landed for those that are going to have recommendations is they're generally considered together. And the reason for that is twofold. One is that somewhat a bit surprising for me, the LAI and the oral data by genotype tracked a bit more closely together than I had anticipated. So coming into that, we think about avoiding first pass metabolism and, how that might relate to a maybe more attenuated genotype effect. But I think because of the delayed release, we do see a similar sort of, I call it stair-step exposure feature across genotype groups for both the oral and the LAI. So they kind of track together. In some cases, there's a bit more variability. So the recommendation is as it stands right now, is going to be together. For those where there are LAI formulations, we do spell that out. And if there's some variability, we have ranges. So like 25 to 50% dose alteration is a common range adjustment, which both accounts for variability in data as well as maybe what you might have access to for different dosage forms.
Fantastic, thank you. We do have another question then for James, actually, but actually first I just see someone's got their hand up, Ethel Wells. So I'll just before we get onto that question, James, I'll just check in with Ethel. I'm allowing your mic and camera if you would like to speak or raise a question.
Yeah, thank you so much to Jeff and James for truly fantastic and gripping talks. It was really great. I'm just wondering, in terms of just practical considerations for management, understanding that keeping someone with schizophrenia on what they've been on in the past that's worked for them is probably first choice. But similar to basically circumventing some of the pharmacogenomic and pregnancy effect uncertainties of like codeine and just not giving codeine for postpartum analgesia, would you recommend just kind of choosing paliperidone that's not hepatically metabolized? And for a second, let's put the renal clearance aside, or maybe say that the vagaries of that being impacted by pregnancy are canceled out perhaps by the absorption limited kinetics of a long-acting paliperidone. But why wouldn't you just kind of choose a therapeutic that does not have those pharmacogenomic or hepatic metabolism vulnerabilities, which have additional uncertainties in terms of how they're affected in pregnancy?
That's another great question. I might let James chime in on that one first. I have some thoughts, but I think that kind of aligns with some of the things he was speaking to. So I'll let him go, and then I can add on if it's. Yeah. But my guess is we're thinking somewhat similar on it.
Yeah, I mean, I think it goes back to when you're prescribing an antipsychotic for a woman who may or may not get pregnant at some point in the future, is to have those thoughts exactly in your mind. I think often it's not considered. It's not even considered, is it? People just get someone well on an antipsychotic and then worry about what might's going to come in the future. I mean, I think I think generally we can keep people well during a pregnancy. So I wouldn't want that to be the guiding reason why you might pick one drug over another drug. I think ultimately it comes back to efficacy. If you can get somebody well, that is the ultimate priority, and then we can work around the rest of it, the changes that we might need to make during the course of a pregnancy. I think, Jeff, you made like the really excellent point is that these aren't drugs that we can quickly make changes to. We can do some bits around adding in oral treatments if we need to, but they're on these drugs because oral treatments they're not complying with oral treatment. So the most important thing is getting somebody well and stabilized. If we can be thinking as far ahead in advance to future pregnancy at the point when we start it, amazing. That should be what we're doing. Yeah, that's my thoughts.
Yeah, no, I'll just, I had exact same thoughts, and just sort of layer on the, in the context of situations where, either that forethought hadn't been given, or for whatever reason somebody started on one of the other formulations, and then pregnancy happens, then the transition across drugs is not always seamless. So and it takes a long time. So the equivalent dose of a paliperidone versus a risperidone, 2-week or 4-week or whatever. I mean, we can estimate that. There are individual differences for how that happens, and it just takes a long time. So by the time you actually, would make that transition, you're probably a good chunk of the way through pregnancy in the midst of all those changes too. So I agree with your sentiments. I just think it's like sort of how reality, gets overlaid onto that. So those are my supporting thoughts for both those comments.
Thank you.
Thanks, Ethel, for raising that. I do have a question here for James, but I think it could be answered also by Jeff from a different perspective. So this is more from NICE guidelines kind of perspective, but I guess any kind of national guidelines kind of perspective could be thought about. Can a community of practice recommend LAI in pregnancy as a second-line therapy based on PK data?
I can talk to that a little bit. I'm part of a NICE guideline committee at the moment for OCD, but I mean, NICE tend to not respond to stakeholder engagement at individual levels. That what they respond to is changes in evidence base. And so I guess what we need to back up all these changes is the evidence behind it. So we need people doing the research, coming up with the stuff like Jeff's talking about. That's what's going to drive the change ultimately. NICE will do like surveillance reports generally it's every few years to look for new data that's out there, which is then what prompts changes into the guidance. But it's the evidence that informs, and I think it's the same for a lot of national guidelines, is that they are informed by new data that comes out. So we just need new data to be able to then twist their arms to be more proactive around using these medicines.
Yeah, for any guidelines, they always get anchored. The top tier gets anchored to published data, trials, like all that stuff, and then sort of expert opinion falls way down, and that's sort of where we are right now. So I don't. Yeah, you're not gonna be able to really nudge that needle, so to speak, in that guideline until we have more data. So it's great question, and also significant challenge.
I think one last question before we will need to close. So a comment and question that someone came away thinking from the first half of the webinar that using LAIs in pregnancy might not be a bad idea. However, after seeing the information on CYP3A4 and other metabolic pathways during pregnancy, I'm now less confident that it's advisable. What do you think the future holds for the use of antipsychotic LAIs in pregnant women? I think that's open to either of our speakers to answer.
Yeah, I mean, it's a great question. I think the future, what I'd love to see the future would be, is being able to have really clear guidance as to what we do for women during pregnancy. You get pregnant on paliperidone, you get pregnant on aripiprazole, long-acting injection, and I think the evidence is really clear that these are really good treatment options, but we don't really know. And I guess it's accepting that up to this stage we have stumbled our way through pregnancies with women and we kept them well on these injections. But what would be great is to be really precise as to what that means as we go through the trimesters at certain stages, being able to do genetic tests on different women and be able to say, right, this is the pathway that you fall into at this stage. These are the sort of things that we would be recommending. That's what I would love to see. How far away that is, I don't know, and I don't know where that is, but I wouldn't let this put you off using long-acting injectables, but I would love to see that precision. That's where I would like to see it going.
Yeah, my intent on presenting some of that wasn't to dissuade, but more inform, like what's, we can quantify changes at the global level, and then sort of figuring out why is sort of that next level of precision. Some of it's, stuff that happens aside from genotype, and that, we would be captured in sort of a general quantification of exposure. And then, layering the genotype on top gets you an additional level of precision. So I think it's basically, I think our hope here is to, gain more insights into what's in the background to, improve that precision, and also guide, like, just knowledge of what needs further research. So I think that's where I sit, and I completely agree with James on his sentiments too.
Fantastic. And it's a nice sentiment thought in terms of where to look forward to close. So I think we're out of questions, and I think out of time. It's coming to about time for everyone's weekends. I definitely wanted to say a thank you to both of our speakers, James Lee and Jeff Bishop. Thank you very much for your preparation, your time, and for answering all our attendees' questions. Thank you to our co-hosts at the PGRN and the Psychiatry Interest Group. And of course, to all our attendees and everyone who joined in and interacted with the session, really appreciate that. This has been recorded, and it will be, once we've had time to edit, ensure that the transcript actually matches what was said. It'll be shared on all of our social channels and around. So really thank you for everyone involved.